So today I have an author, songwriter, singer, and a board-certified pediatrician at the Parker Adventist Hospital and Southlands Primary Care here in Colorado. To her patients and their family members, she's known as Dr. A. She's also an attending physician at the Banner Medical Group in Northern Colorado. She has won the Best Physician Award, the Excellence in Service Awards consecutively for the past 5 years in these establishments. She is the Vice Chair of Pediatrics and sits on a medical board. She is a member of various committees, including the Ethics Committee, Mother Baby Unit, peer disciplinary boards, among others. She's currently the lead physician of the safety campaign at Centura and the clinical lead for mission integration in clinics. Ladies and gentlemen, let us welcome Dr. Olukemi Akinrinola to Morbidity and Mortality podcast.
Thank you so much for this honor. I'm very, very excited to be part of the Morbidity and Mortality podcast. And I want to say to Dr. Uzonduka, you're doing a very good job. We're really blessed to hear all the things you're highlighting in your podcast. I think it is a very vital tool in educating our people and educating the whole world, generations unborn too. So thank you for having me here.
The honor is mine, Dr. Kemi. I really appreciate that accolade. It means so much to me. I appreciate that so much. For today, I will call you Dr. Kemi. I hope you don't mind.
That's fine, absolutely.
All right. So Dr. Kemi, thanks for making our time to come to my podcast. I know it has been a very busy and stressful time for you all in the healthcare field. Let me use this opportunity to give a shout out to all physicians, nurses, everybody that has been in the healthcare industry this past few months, 9 months or so, especially with the COVID. So we appreciate your thank you.
Yes, so welcome. Thank you very much for saying that. It takes a team, and you doing this podcast and talking about health, you're part of the healthcare industry, so we appreciate you as well.
Thank you so much. You've been so kind and generous with your words. I appreciate that. So Dr. Kemi, initially, when this COVID started, it was said that it does not affect children. But now we know that it does affect children. And sometime in the past, I read a study, I believe it was published on Lancet, where the authors acknowledged something called hyperinflammatory shock in children. And that this hyperinflammatory shock has features of Kawasaki disease. Is it possible for you to explain more about this hyperinflammatory shock in children and, the features of Kawasaki disease? And have you seen this type of shock in the patients you see daily in your hospital?
Thank you for that question. Now, so the hyperinflammatory shock that is associated with COVID-19 in children is not a new phenomenon. And I'm glad you mentioned it's a Kawasaki-like, phenomenon, which we all know used to affect viruses. We don't know which kid would be, prone to that. But it's not just the COVID-19 virus that has done similar things. So the Kawasaki phenomenon is an hyperinflammatory shock-like event that affects them, and they have classic signs. And so when we see those signs where they have fever for more than 5 days, they have, red lips, they have swollen tongue, they have rash. It's like they're peeling their skin and peeling inside as well, many times affecting the heart, the aorta. We can find it with any virus, like I said. So many times when we see that, most times we don't even care about the name of the virus, because many kids are always carrying one virus or the other. That's why we tell kids, once their fever is getting more than 3 days, going to the 4th, 5th day, we're already worried that they're going into this hyperinflammatory shock-like event. Can happen with the common cold, can happen with parvovirus, the flu, or the flu-like illnesses. And so very interestingly, we're finding that that can happen also with COVID-19 virus. So I just want to make it known that it is not so special. This phenomenon is not special with COVID-19, but yes, it has been found. And then I think that was where the fear came in, because initially we were like, no, the kids are kind of protected. And we started seeing this Kawasaki-like event, which is the hyperinflammatory shock syndrome, and then traced it back and seeing that, okay, yes, COVID-19 also does that. Now, I've seen lots of kids with this, this phenomenon in my practice. With the COVID-19 vaccine, I've only seen one kid that did that. And they also did the same scenario, more than 5 days of fever, then they begin to have the peeling of the skin. And of course, you're already on high alert once you see that. Now, because of the pandemic, we're testing the virus to know what virus could have caused it. And so in retrospect, we found out that the kid had COVID-19, a 22-day-old baby who eventually did well. So yes, I have seen one from COVID-19, but lots of other kids from other viruses.
Interesting. And some studies have shown that children are not, significant drivers of this COVID-19. And these studies, like the one I read on pediatrics, it was titled COVID-19 Transmission and Children. The child is not to blame. So in this article, it claimed that children do not transmit the virus to adults. Rather, adults transmit the virus to children. Is this in line with what you have been experiencing as a pediatrician?
So a word of caution about this, because I know that lots of studies are coming out with this. And, lots of people are studying and lots of researchers are studying different modes of transmission. How are they transmitted? Yes, the child is not to blame in a generic term for the COVID-19 pandemic that we have ongoing, because we have found out that the incidence of children that have the disease compared to adults is lower. And maybe the study just checked, I'm not sure if it was a retrospective study, if it was a prospective one. I don't know if they had enough subjects. But I don't want us to categorically use this study enough to say, oh yes, definitely it's only the adults that transmit it to children and children do not, transmit it to the adults. It may be in that study, we're seeing that that's happening more. But generally, coronavirus, which COVID-19 is one of the types of coronavirus, is something that the kids carry all along. We didn't know this before, that the COVID-19 was really like a coronavirus. Now, I've talked to many of my patients that when you look at the Lysol or bleach or many of those, antiseptics that we've had in the country for so long, coronavirus is one of the things that those things, the bleach can actually kill. The kids reign and rule in coronavirus. They've seen it over and over, the different types of them. Now, the COVID-19 is a new one, so it's a new type, but the family is something that the kids are used to. So I know that for sure, the kids are not transmitting the COVID-19, as much, because one of it is that they've seen similar, they've seen a member of the family over time, and they've already gotten some resistance to it. And so even if they had it, chances of them transmitting it, because their immune system, if it's working, can take care of it normally. Also, we know that there are ways that kids can transmit things. Sometimes they cannot aerosolize, meaning they cannot make the secretions, they cannot make it into air particles until they get to about 6 years old. And that's one of the things that we've noticed in TB, tuberculosis. Very young kids cannot transmit tuberculosis. They can have it because they cannot form that sputum and aerosolize it in a way that it can be, contagious to other people. And so the studies are still ongoing. So we know for sure less than 6 years old cannot do that to many of their viruses or their bacteria. And so even if they have it all around them, if the mode of transmission of that disease needs aerosolization, then those kids cannot transmit it. But we are learning that COVID-19 can be transmitted by secretions as well. And so that's where I want us to have the word of caution to say, they cannot transmit it altogether. Also, as a pediatrician, children, they have different categories and they do different things at different ages. So of course, when you're saying 0 to 2, definitely 0 to 2 years old, Abiel is sneezing and all that. 2 to 6, they can do other things. Once you're more than 6, you can do other things. So I would assume that when they're saying child, they're talking about the very young ones, like less than 4, essentially.
Right.
But even at that, a word of caution that we still don't know a lot of it. We don't think the child is to blame, but the blanket statement that it cannot transmit it may be not conclusive.
Right. I do agree with you, and I should have checked if the study was a prospective or retrospective study. But I promise my audience in my next episode, I will, clarify that and let them know whether the study was a retrospective or a prospective study. And there are so many things we are still learning with this COVID-19, and I think I should have started with this question I'm going to ask you, but. Let me still ask it. I will assume for a minute that some people do not understand what COVID-19 means. So please, what is COVID-19? How is it different from other coronaviruses?
Okay, so COVID-19 is a new SARS/CoV-2 virus. We've had families of it before. It is a coronavirus in the sense that in the shape that it has, it's like, if it's round, it tends to have a color, if you look at it in the microscope, it has almost like a, yellowish red color. And that's why if you see with some speckles and, has the proteins around it, the way it is shaped is what gives it that name, coronavirus. So it's in that family. Then the COVID-19 is a new a new type of it. The full name is the SARS/CoV-2. We've had one before that did not have the one name, which was regarded as the bird flu. It is a flu-like virus, but it is different in the shape of the shape it has compared to the general flu, influenza that everybody knows. And the shape is what affects how it is transmitted. The shape is what affects how the treatment will be done, because how does it how does it bind to your own parts of your body, and how does it begin to do things in your body compared to the general flu? We do know that the COVID-19, we got the name 19 because of 2019 when it was publicized, when everybody knew about it, is a very new type of coronavirus, which we already explained before, has been in existence before now. It is also known to be a little bit more virulent. It easily changes its shape, easily changes the way it attacks its host. And of course, because it was new, was what is this kind of phenomenon? Because we've known the normal coronaviruses and we know how they adapt and bind to our cells and how we can produce immunity against it. But then the COVID-19, which is the SARS-CoV-2, it was a new one. So the way the proteins are all binding onto the cells of the people, it just totally can do a lot of things. It has a general tendency to cause autoimmunity and cause a lot of proclotting nature for adults, and then for children, like we talked about, the hyperinflammatory responses. So it's just called COVID-19. It's a flu-like in the sense that it does the general symptoms that we've known about the flu, but it is just that part. That's why we're calling it flu-like. It has other parts of it, which is the autoimmunity, fighting the body because of the way it binds to the cells of the body. So initially when it came about, everybody was thinking of the respiratory part of it and calling it a flu. But then we now found out that no, it can attack every cells and begin to make your cells fight against itself, causing some hyper, inflammatory response, even in adults. But the way adults present theirs is different. Adults present theirs by breaking things in their blood vessels. And so organs can die, the kidneys can be affected, the heart can be affected, they can form clots, they can form, like in the lungs, where everybody was thinking of, oh, it's just a respiratory thing, and putting them on the ventilators. They found that that's not the mechanism it was causing. It was causing like minute clots all around the body. And so it's a very virulent virus. And with more studies that have been done, it's shown that it can change its modus operandi, like I said. And so that's why just, you can box it, you can have a respiratory symptom, you can have, just like pain, just like an ischemic syndrome, where it affects your blood vessels and it doesn't supply blood to an organ, and that essentially that organ is dying. And so many things like that. But yes, that's what COVID-19 in a nutshell is.
It is a very dangerous virus,
Very dangerous.
Yeah, I've I've heard I've read about what is called long haulers, people who have, had experienced COVID and survived, and but they still, have, some kind of symptoms, and, other, they're still sick somehow, either they're experiencing swollen leg, or they are not sleeping well at night, or still losing appetite, and several things, so this virus, it should come and go. Yeah. That's me venting right here. I'm sorry about that, but it should come and go. So, Dr. Kemi, I know you have, with some respect, addressed my next question, but I still want you to please tell us what you know about COVID-19 amongst kids, kids 0 to maybe 6 or 12, or including its clinical manifestations.
So in COVID-19, like I said, most of the kids that will present, if they have an intact immune system, they may just have like the typical viral picture. Most viruses do this, I'm going to say just a general thing that most viruses will do. First 3 days, they may have a little fever. The fourth day, the fever may go down, and they may have other symptoms. It depends if they're having, if it is an upper GI, so gastric type of virus. So from the fourth, fifth day, they may have like a, diarrhea or nausea, vomiting, and then they start to get better. And by the 10th day, most of them are better. If it is like a respiratory virus, first 3 days, they may have a low-grade fever. From about the third day, runny nose, cough, and, some of them may have more, respiratory, just having more, maybe shortness of breath for a short while, but then they start getting better about the 7th day, 10th day, they're better. Now, if it is a type that has a rash manifestation, so a virus like a measles, or even the typical hand, foot, and mouth virus that's not like very deadly, they still do the same thing. They have that first 2-3 days of fever, then you start to see the rash. And then the rash may stay on for about the 5th, 7th day, 10th day, they're better. The thing about coronavirus, the COVID-19, is it can show all the symptoms. So I gave the very common symptoms of viruses, because when a pediatrician says it's a virus, people just wonder, so what does that mean? It just really means it should be self-limiting, it should run its course, and we already know the trend of most viruses. Now, it depends on what type of virus, so we know what to expect. But the COVID-19, and like we said, can operate in any of those dimensions. It can act like a respiratory virus, where they're having the runny nose, the cough, and then they're having fever, and then they start to have the GI symptoms like the diarrhea, vomiting, and then they're maybe a little bit dehydrated, maybe they are not. It depends on how mild, if it's a mild, moderate, or severe infection. And then they can have the rash manifestations. So you have all that, with the COVID-19, the presentations are multiple. And so you can't just say, you can't box it, like I said. Now, the people that we've seen, also with the different age groups, they tend to have different kinds of symptoms. We have to look at people as intact immune system, no chronic ailments, previously healthy. That's the word I call it, like not taking many medicines for different things. They tend to have the mild forms, except they go into that new, new line of the hyperinflammatory symptom. So they could have any of the symptoms that I said, just, runny nose here, or just feeling nauseous and all that, or not able to taste their food, or just having a rash, or just feeling like the skin is peeling, and get better. Now we have the ones that they have some chronic ailments, like heart diseases, respiratory conditions, asthma, or their lungs are already, maybe cystic fibrosis and things like that, or they have immune problems. They can have any symptom. So they can start with just runny nose and maybe no fever, and the next thing they're having shortness of breath, needing to be hospitalized immediately. In children, we have had more mild to moderate, symptoms, except those ones that have had either a chronic condition or the hyperinflammatory symptom that has resulted in morbidity, or actually mortality. So sorry, mortality, yeah. The older kids, however, as a pediatrician, I always like to correct people that I see patients 0 to 21, very interestingly. So that's, in pediatrics, and I think that's why some of the politics came in to say kids can stay in their parents' insurance, because pediatrics were trained to sit 0 to 21. So I was talking about 0 to 6, for those symptoms. But when you go to about the 6, going to the early teenage ages, they may just have joint aches, essentially. And then, just joint aches, may not have any respiratory symptom, no rash, nothing. But they may have just the joint ache, but they can transmit it to as many people as they come in contact with, depending on what they're keeping the protocols in. Now they get to the older teenagers, going to the young adults, 9 to 20, then they begin to have some serious symptoms. So I've had many patients about the 18, 19 being, having respiratory problems, needing the steroid, needing, the medications that are, these are FDA approved. And we think, like we said, the studies are they're still being done. But we think that because coronavirus is the zone of children, like I said, the family. The younger ones, yes, they're always having things. But as they get older, the immunity they may have had to the family begins to wane. And so that's why they tend to have a more serious outlook and symptoms compared to the very young ones, and, similar to what the adults do. The youngest child, like I said, that I've had was a 22-day-old baby and doing well now. And they just presented with bloody noses, so just like it's like a hematology symptom. So like we said, coronavirus can affect any system. So it wasn't just waiting for runny nose and all. The child was just having bloody noses. In Colorado, it's very dry. So the first thing that came to mind, maybe use saline drops, use the humidifier. And we were like talking about volumes of blood. We're like, okay, this is what we call the DIC, like the clotting factors are no longer in cascade. They're all out of whack. And so at that point, we really need to have the child go to the hospital, hospitalized, transfused and all, child maiden. But yes, so it presents, your guess is as good as mine in the presentations. But like I said, if you just think of the 3 main ones of either the rash, the GI, and then the respiratory, and then, joint aches, joint swelling. Some kids describe it as feeling like being run over by a tractor, just extreme fatigue. Like they're not having any runny nose, they're not having fever, which comes to one of the reasons why we've been saying that checking the temperature is great, but maybe was not such a wise thing to do, because many of the people don't have fever, right? And so they just feel like run over, just can't, and then eventually we find out that they have the COVID-19 back.
Wow, I'm so glad that kiddo made it. I don't know how the parents will feel, and even you who is the physician, I don't know, because I know you are very empathetic, and wow, I don't know how you guys are dealing with all this, because I think that there should be a department in every hospital that should be taking care of healthcare professionals. If they're not, if the hospitals don't have those departments, it's high time they, start thinking about, what to do with you guys who, you guys are being stressed too. I mean, you're human beings. Despite the fact that those people coming to you are not your immediate family members, you feel for them too. You're drawn into their pain. So, I'm just, thinking.
I think, thank you so much for making that recommendation. I think based on what has happened, many hospitals are talking about helping all the healthcare workers to, to have a place where they can debrief, and if they need to talk to someone. The COVID-19 is not just the patient thing. It's like every, every sector of the economy, of, the whole world. But in the health industry, it's not just the fact that you're afraid that you might get this. You're also thinking of the patients. You're also thinking of, how do we stop this? And it just goes on and on and on.
Yeah.
I give one joke. I usually like to, being a pediatrician, I deal with young kids, and I like to wear very bright clothes. And sometimes the parents would joke and say, oh, my daughter said she's dressing like Dr. A and all.
Yeah.
But when the COVID-19 started, we started wearing scrubs because, the kids sneeze on me. This is my zone. I tell parents, don't worry about it. The baby poops, it's fine. I help them clean it. This is my zone of, it's fine. Just sneeze on me. I'm a pediatrician. I just get home and change. But when the COVID-19 started, we had to, except you're contaminating all your wardrobe, contaminating everybody at home. So I started wearing scrubs and, no longer all those bright colors.
Right.
And I have parents come and say, oh, maybe the world is actually coming to an end. You're wearing scrubs. You understand what I mean?
Yeah.
Like this, but I think all of us are taking it, differently, but it is a tough thing. And I think we're making progress now that we know a little bit more about the presentation and we have availability of testing. I cannot overemphasize how that has helped to contain the evil that this is, because then we didn't know who had it. It was just a few people that had access to the test, and anybody could have it. But the availability of testing also helped. We can quarantine, we can isolate, we can put proper protocols in place.
Right. I'm glad you brought up the issue of testing. You see, I've been a proponent of surveillance testing. Reason being that, to me, it's the best way to separate those who have the virus in the population from those who do not have the virus. And I also think that it will reduce the burden of contact tracing, and I know countries with a high positive rate are very unlikely to be testing widely to find all cases. The World Health Organization has suggested a positive rate of about 3 to 12% as a general benchmark of adequate testing. And here I'm talking about the PCR test. Is it possible for you to throw some more light on testing and why we are not doing massive COVID-19 testing in America?
Well, so the testing has been, the fact that we even have a better availability, it's not still the rate at which it is expected, it's still not what the WHO recommended, has even improved, has improved the lives of people. And even though we know that we're still seeing high mortality of COVID-19, I think the reason is still because we, like we said, we're not testing enough to be able to put those proper protocols in place, because what you don't know, then you don't know how to deal with it, right? But when we had the testing, it got things better in the sense that the health profession did not feel, let me not say not overwhelmed, because I think, generally we're still, but did not feel like you're fighting with, like a monster you had no idea what it was like. You didn't even know if your colleague had it. I always like to say we had one of our colleagues that had the COVID-19, and the only symptom she had was backache. And she's been going to, like we talked about, we've been doing all the screening. She was fine. She's been seeing patients. She's been doing very well. And I know that we talked about this podcast and she's been saying, it's okay for me to talk about this. So she's been doing, she's been seeing everybody else, just like we have been doing. And she was going to see a physical therapist. And just by the way, it's like, okay, let's just do a COVID test now. No fever, no typical symptom, an adult, of course. She did that. But the same day when she was doing the PCR testing, of course, typically when you do a testing, then you have to, you have to be in, some quarantine. There was no known exposure. She just did it because this backache is not going away. And she's, she knows enough that it could be this. And it turned out to be positive. But about the same time when she was doing the testing, while she was waiting for the results, family members started having symptoms. Now, they started having weird symptoms. Some of them were having the loss of taste. Some of them had the respiratory symptoms. Spouse had to go to the hospital, shortness of breath. She that was the contact to the family had only backache, and we that were contacts with her, she would not have passed that, we would not all have known, we would not, because she didn't have the typical symptoms. And so that brings us to why we're not testing enough. I know that in some centers and in some, some university systems, they're making their staff just tested. Just because you're in contact, we're doing all the protocols, you're wearing your goggles, your masking and all. But just in case, because you have the asymptomatic carriers, you have the ones that can also send it to, to give it to others. And I think one of the reasons why we still have a high mortality rate is because there are lots of asymptomatic people that are carrying it, working even among sick people and just sending it. I mean, just imagine, my colleague, and she's been, she's become vocal about this because, how would she have known that she had it? It was not just a matter of, oh, you could have COVID, we were all joking. And he's like, no, I don't have COVID. Well, I'll do the test. And then turns out positive. How long she's had it? How many people she's giving to? We know for sure the family that she's giving that to. So we do need to have better testing protocols in place. It's available, but I think people should not feel they should not feel scared to get the testing done. It's the same if we think about the time when HIV was reigning. That was the stigma, unnecessary. Having COVID is not, we should not stigmatize it. It's not like, it's not always because you did not do the right things. This is something in the community. Anybody can have COVID-19, right, at this point. And so the fear of not wanting to test, even when you have symptoms that may be concerning, is actually spreading it and making this pandemic, stay on longer than it should be. I think there are some political reasons too that are ongoing, which, that's just another world on its own that has also stigmatized, the testing. I get from patients all those things about, oh, if I get tested, my phone knows, people around me know, and they've made it into this whole thing where it's not supposed to be. It's supposed to help people contact trace and be, oh yeah, this person may have it, just to help our community, and so that we don't have 2,000 people dying of COVID-19 daily. I mean, sometimes we've gotten so used to it, we're not even looking at what the rate of mortality is. It's unbelievable. And so, like people have said, if we had a Boeing 737, and I pray this never happens, but we have a plane crash, you're having like 5 plane crashes every day. Would it take, I think it would cause a standstill. And this is the same kind of amount of people that are dying from COVID-19, and we've just gotten a little bit apathetic. Doing the testing cannot be overemphasized. I would love to see that in all clinics, if we can get it once a week, even if it's a minimum. I've had to do the testing only because I had some symptoms and I wanted to check. I'm not required to do the testing. So those are what we're talking about. Meanwhile, I've had a patient that I've, not just one, I've had lots of patients, but because just because we're trying to minimize it, we don't have enough. We have to give it to the people who have symptoms. We have to, ration it, So, but I think that's one of the things that has helped to spread this so much.
Right. You brought us so many important points there, and one of it is stigmatization. I think we should begin to advise people not to feel so stigmatized about having the virus. It's out there in the community. I mean, they didn't bring it to themselves. So, and and also the point that your colleague who was initially asymptomatic has become vocal when she realized that she had the virus. We should also continue to encourage people who were asymptomatic initially and later came to know that when they got tested and they became positive, they should begin to let other people who are presumably asymptomatic to begin to go and have the test. And when they have the test, they should begin to educate others, about how serious this virus, is, and because you raised those 2 important points, I want us to stay on testing for a while, if you don't mind, Dr. Kemi. So to my understanding, there are 3 types of COVID-19 testing. Am I right?
Yes. Well, it depends on,
Okay.
depends on who's counting.
Right. Okay,
Yeah.
right now I'm counting. So if that's fine, could you walk us through what they are and what they mean?
So, I mean, the very publicized ones are the rapid testing. It's a not PCR testing. It's most of the ones, and they're widely available. And I think actually this past week, the FDA actually just they approved another one that at-home kits that people can actually buy. Now the positivity rate is about 75% sensitivity. Sorry. So that means if you really are positive, then you are really positive, right? And then you have the PCR testing, which is not widely available for private use. It's really more expensive because it's more sensitive. And so that means when you are positive with the PCR test, very almost likely that you are. You can almost say, yes, that person is positive. And when you're negative, you can almost be rest assured that that person is negative, meaning the test is doing what it's supposed to do. If it says you're positive, you can take it home that you're positive. If you say you're negative, you can take it home that you're negative. Now, there's still some false negatives and false positives, but the rate is lower compared to the rapid test, which is a non-PCR testing. Now, so I don't know the third one you're talking about, but I think the third one might be another non-PCR testing, but the gold standard right now is a PCR testing that shows that you do really have the virus. It's based on the fact that we can see the virus in your system. Right. And so because of that, once we see it, once we say it's positive, you have the virus. That's why we see it in your system. Now, there are the non-PCR tests is like there are markers, there are other things that the virus gives off. Like, I'll just say in layman's, like, the aroma, the smell, looks like, acts like, and all. So that's what is tested. So if you see it, then you know that you have it. Now, I think the third one may be what you're talking about, maybe the antibody testing.
Antibody, yes.
Yeah, the antibody testing. Now, the antibody testing is the one that, okay, yes, your body has seen that virus. That's the third one. Yes, and you're right. That's the third one. In pediatrics, excuse me. I think did I lose you? Sorry.
You're good.
Yeah. In pediatrics, that is essentially not being used. So maybe that's why I just said we have two types of viruses. And you know why? Because the antibody testing it's not sensitive to the COVID-19 as much.
Okay.
And remember, I said that in the zone of PEDS, coronavirus is what they live with, especially the younger kids. And so almost all of them will be positive with the antibody testing. Because that shows that you've seen that virus, your body has fought it before, and we can see the trace that you've had, you've conquered that virus at some point, or you've seen it. And so if you had, it's not specific. It is, it's the ones that are widely available is to the family, the coronavirus family. It impedes because of that. Now, but I know in adults who are using it, and so it just tells you retrospectively you may have come in contact with with COVID-19. So the PCR is a gold standard testing. It is more expensive. It is done usually in the institutions. So, it's not approved FDA has not approved any. I don't know if there's anyone that's been approved for at-home use, and just because of the technicalities and, availability, but it's like a gold standard. And so sometimes if someone has done a rapid testing, we would still recommend they do a PCR testing. At least that's the standard for our hospital. If any of the staff has done a rapid testing, it's just, okay, what do we do? Do we start, are you being isolated or not? It's something like, what do we do from step one? What do we do? But then to really see if you've gotten it, we would go ahead and do the PCR testing. Now, the PCR testing needs to be more available, like we're saying.
Right. Sorry, listeners, we had a few technical issues there, and we've resolved it. And, just like technology first, a lot of things first. And right now, Dr. Kemi, let's talk a little bit about COVID-19 vaccine. What can you tell us about, vaccine development and deployment. I totally understand that this might not be your forte, but I know you can tell us something about COVID-19 vaccine development and deployment. And if you don't mind, please can you also tell us the different companies that have been involved in the development of these vaccines? Where are they now with all these vaccines?
Yeah, so I mean, we're excited that the vaccines are here. The FDA in the United States has approved the vaccines, the ones that were um, manufactured by Pfizer, though it's a conglomerate of scientists that got this done. But then we had the company Pfizer, which is known to have developed lots of vaccines and marketed lots of vaccines in the generations past. So it's not a new company to vaccinations. So we know that FDA has approved that for the use in the United States. There is the concern of how distribution is going to go. We know that there are supposed to be phases, and phase one should be to the frontline workers who are health workers, people who are in the front line, and the older and the aged in the nursing homes. At least that's the plan. And then we have the second phase where everybody that wants it, may be able to get it, may be able to get it in some pharmacies. I know for sure there are just two pharmacies that have, been publicized, the CVS and the Walgreens, as well as the doctor offices. And then I think the third phase is we're hoping it gets to the point where people can get it, just at any of the pharmacies. So like your regular grocery store pharmacy would be able to have them. But now it's been rationed to the point where give it to the frontline health workers first and to the older people, aged people, the nursing homes. Now, about the vaccine, a lot of talk about data and safety and all that. And, but I think as a pediatrician, as a scientist, I always know that there are processes that we should follow. And I think it was publicized that this was done. There are questions about the fact that it's supposed to be, that it is an mRNA vaccine, which not going to too many details, is just that it is a type of vaccine that can be easily produced and manufactured. I mean, that route. I know for sure, I was reading and looking at some of the profiles of the people that were involved in the work and the study of the vaccines. The mRNA vaccine production it's not a new thing. It's always been in the works. I think we know historically the United States has always been years ahead of their time, right? And so as of 2 years ago, work has been going on about using an mRNA vaccines, and they've done the framework, what would happen if we needed a vaccine that was going to take that approach. So I know that there was a lot of work that was done before, and then when the COVID-19 came on, looked as though they used that platform and that framework to get this vaccine out to people. Tiny details, there's still kinks to be worked out. For instance, do we have enough subjects for the younger children? I'm a pediatrician. Are we going to be giving vaccines to babies? We know for sure, like the flu, when the flu first came out, the flu vaccine first came out, we had, it came in batches. The very young kids were not given, until we knew more, until we had enough studies. And till date, we still don't do flu vaccine for under 6 months old babies. Till date. Now we know when the flu vaccine came out, we took time to study, and they found out that there's a killed one and then there is a live one. And we know that the live one, we would not give it to a kid that's less than 2 years. All those restrictions are still in place till date. We know that the live flu vaccines, and I'm using that, because that's a seasonal vaccination protocol that we have on, and which we're hoping the COVID-19 would be. We know that that if the first year that a child gets the flu vaccine, if they're less than 8 years old, they do a 2-dose series so that they can, it's more like you're jump starting them. So they get one, and then a month after they get another one as a booster, and then subsequent years they get one like everybody else. So all those protocols came after a while, even when the flu vaccine was developed and was publicized. It wasn't just like from the first day those things came up. Initially it was like maybe don't give under 5. More studies were done, and then they started going there. So I think COVID-19 vaccine would probably be the same line. Being a pediatrician, where we're looking at the academy and we're looking at AAP, they're working with them to know how do we distribute this, who needs it, who are the kids that we will give it to, and how do we. So, but I know for sure for adults and the health workers, they will be the ones that will get it first. So probably not children until we develop better protocols and know for sure how to give this.
Yeah, thanks. I was gonna ask you a question surrounding the thinking behind the US deciding to give frontline workers the vaccines first. But in the UK, they decided to give it the elderlies, and not the frontline workers. But we're not gonna go into that today because of your time. So I want to respect your time. Do you mind if I ask you 2 more questions, please?
Oh, that's fine. Absolutely.
Thank you. So a lot of things are puzzling to me with regards to this virus. One is something called Operation Warp Speed. Why was it necessary? It seems to me that it was politicized. I mean, Operation Warp Speed was politicized, and that may have resulted in people not willing to, first of all, volunteer to the vaccine development. And also right now, we're hearing that people are not willing to take the vaccine as they are available.
So honestly, as a doctor, sometimes when I look at some of those things, and I just, there's always government and protocols and, give names for different things and Operation Warp Speed. And I thought initially, and looking at what they did, what they said, it was supposed to be like a partnership of, stakeholders in the industry, and let's use the word experts and people who can get this delivered quickly. It's just like in any organization, you make a little committee of how to do this. So we want to start doing, say we're now doing the safety plans, a new one, and they come together. And so initially, without going to deep details, that was what it was supposed to be, like an expedited committee of experts and stakeholders to get this done. And with people who have already done things like this before, and people who have the ability to, they already have, the form, they have those guidelines in place, they have the systems in place to be able to get things going fast. I know it has the HHS. I worked with the HHS at some point, Department of Health and Human Services, which is like the Department of Health, essentially. And of course, they have to be involved, the CDC, and then they begin to add other groups, the biomedical researchers and things like that to form that. But I think the mistrust may not be as much as the Operation Warp Speed, as much, it may not be because of that name or the fact that there was a committee, which is essentially a partnership, as much as the response to COVID-19 infections and, the pandemic in the US. If you initially say that it's not a big deal, don't worry about it, we'll all be fine. And then you don't go back and say, I was wrong. So like I tell my patients before, where we say, yeah, the kids are they're well protected. And now I go back and say, well, they're well protected, but believe me, the kids can still get it. You have to go back and say, with what we know now, it's not the way we said it. If you stay with statements and almost like, when you say your word means power, when powerful people who matter stay on statements that negate the science and the reality on ground, you begin to have people just wondering what to believe in. Of course, nobody knew, like we said. I emphasize the fact that the health industry, the healthcare workers were overwhelmed because it looked as though when COVID-19 came, it was like a monster that we did not know about. But believe me, there are institutions that were made in the United States to look out for these viruses before they come in, and attack us. And it shouldn't have happened the way it happened. There are people who are paid researchers who have been working on COVID-19 like things for generations. And, some of them were starved, of finances, or maybe they just did not progress as much. And when this pandemic came in, it looked as though, where did it come from? So we already lost time and lost resources, and we could not foresee. And then we did not have any policies in place. And when it was here, we denied how virulent and how the sheer mortality. And at some point we were even the whole country was denying the number of cases. And we were fighting about testing, why we should not test people. And then we go on to say the people that are dead are not actually dead from COVID, and then all of a sudden then we form a warp speed. Of course, you're going to be concerned as a normal citizen, like, wait, are we really, now, are we saying it is bad? Or are we, I think generally, like I said, my patients would say, oh, maybe I'm not taking it seriously enough. When they see someone they believe has been credible, they're used to, because they know I'll tell them the way it is from time, wearing scrubs. And some of them get a shock, like, okay, maybe we're not really taking this as seriously, because they've been hearing a lot of mixed message. The committee was supposed to be a partnership of people that can get things done, but it brought in a lot of concern, because hitherto we said it was not a big deal. Now, the other part of the vaccination and the problems with it is, so COVID-19 mortality, we know this is a morbidity and mortality podcast, has affected disproportionately the darker hue people in the United States. It's not all over the world, because in Africa and other places where we have the darker hue, they don't have the same mortality that we have here. There's not been a lot of studies besides just the general assumption of socioeconomic status and socioeconomic factors for people to say that's why it's affecting them disproportionately. There's not been enough. I know for a fact, because I worked in transplant committees in Nigeria, St. Nicholas. I worked with the kidney transplant. That was the first hospital that did kidney transplants in Nigeria. We started with a partnership with the UK. I know for a fact that people with melanin, because of what we call the HLA type they have, we have a higher tendency of rejection of things, like our body fighting. The immune system, our cascade, we're pro-rejection. It's more like we're more pro-rejection. That's why we have more things like lupus and arthritis and some kind of autoimmune diseases more with the darker hue. It's not always socioeconomic factors, or the fact that they eat bad, or the fact that they don't see doctors now. Those factors may be there. The mistrust of the system may be there, but there are some pathophysiological factors. And with the COVID-19 being, a virus that tends to produce autoimmunity, some kind of that, with people having microvasculature problems, and they could be having strokes and all that. There is a thought that that's why it's affected people who are more pro to that, by their HLA types. I don't know if studies have been done about that, right? So, and that would affect how the vaccines should work for those people. So if the virus affects people disproportionately, then you want to know why those people are affected, and not just, just come to conclusion because of A and B. Studies need to be done about that. And then if you're getting a vaccine, you should really work on making sure that vaccine does not have the same characteristics that makes it more disproportionate to this group of people. As a scientist, I want to say we are all human. We all have the blood, but there are some different genes that make some people more prone to different things. That's why you have eczema more in the darker hue. It's still immunity related, hypersensitivity related. That's why you have asthma. It's more related to the darker people. It's not because they smoke more. It's not because, they're worse. And that's why COVID-19, there's some things about the COVID-19 virus that makes it also affect them more. The vaccine should look into that.
Wow, Dr. Kemi, wow. I know you are a clinical professor, and I hope your students are listening to this podcast because you've given them a research topic right there. Why they should listen so that they can get out what the research topic is. I don't want to, give them the research topic right away. So, and you have thrown out some acronyms here. One that I'm interested in is the one called FDA. It looks like they play a critical role in protecting the United States from threats such as emerging infectious diseases, including this COVID-19. So, and FDA, from the little I know, is committed to providing timely guidance to support response efforts to this very pandemic. So, given this little picture that I just painted, was emergency use authorization necessary?
I I think based on the incidence rate of COVID-19 and mortality rate, and the fact that it's not slowing down. We had the first phase, and it's nothing compared to the second phase, with a growing apathy of normal guidelines that were instituted by the CDC. I think the emergency use could be argued and say, to say what way, there has to be a way to flatten the curve. The
That's right.
people are not going to, they're tired of not wanting to be together. I hear people saying it, not just because they're selfish, because sometimes, people are just selfish. They want to be together. Some people look at it's their life or death. I'm leaving, but somehow I'm not leaving. I've tried for a few months. And over time, it's like, oh, something's going to kill someone. This is not just the people who are disregarding how bad this virus is. These are people who really recognize how terrible it is, and the fact that lots of people are working hard to get it under control, but just cannot abide by how strict some of the guidelines are to be able to get this under control. So some of them are breaking the rules, right? And not because they're careless or just don't care, but they're like, if I must leave, then I should leave a little bit,
Right,
and
right.
the growing apathy, I think, also led to a higher spike in the second, phase, and no decline in sight. We're closing schools, we're doing all that. So because of that, you can argue it and say, if the researchers have done their job and have done all the things that needed to be done, and we have over 2,000 people dying daily from this virus, if we have developed a vaccine that we know can slow down the rate of infectivity and people dying, we might as well use it. Are there other reasons why some people might want emergency use? Yes, maybe. Political reasons, maybe all the other reasons. But from a scientist point of view, or maybe from a clinician point of view, high time, we need something.
Right. Right. It's high time we need something, Dr.
We need
Olukemi.
something. We need
Yeah,
something.
yeah,
Yeah.
yeah. So, I'm in support of your point of view. Given the number of deaths occurring daily and the number of cases, in the US only, is very, very alarming, and some we need something, just like you said. And we have covered a lot, and I just want to say thank you, Dr. Kemi, for coming to our podcast. And it has been a very, eye-opening one for me, and I believe it's been one also for my listeners. So, having said that, I will urge you to give us your closing remarks, please.
So thank you so much, Dr. Uzo. It's been a really good time being here. Um, I just want us to know that tough times don't last. Tough people do. Our generation we're facing is like a fight of our lives. And every single day that we're able to be alive and to get things done. If you're a healthcare worker, Dr. Uzo, it's fantastic, educational tool that you're putting out. It's a blessing. I look at some of the names of the people that have died, unfortunately, from the COVID-19, and, very fine people, finest people. Some of them would do anything for their patients, as doctors that have just died, and then, other people, just going about their lives and all. So it's a tough time, but we are tough people. We had the chicken pox, we had the smallpox, we had the polio. Polio has been eradicated in the United States. When I talk to my patients who don't want to do vaccines, I was like, I can show you some videos, because I am blessed to have schooled all around the world, in Nigeria, in Africa, in the UK, and here. And it's like the fact that you don't see these things does not mean it doesn't happen. There are people who are not taking these vaccines, or they're still having these diseases because sheer economy, they cannot afford them, because we've eradicated them with, patience, with adherence to strict guidelines, and just seeing the light at the end of the tunnel. So as a pediatrician, I see that, and I think we have to have that mindset to be able to overcome this. I recommend that we keep the CDC guidelines as much as we can. Use your mask. Don't go out if you don't have to. Most stores have, they have the online options. Minimize your contact with people if you don't have to. Wear glasses, wear goggles, wash your hands, avoid touching your face all the time. All those simple things. Wear your mask. Wear your mask. So get the vaccine if your doctor says it is, you qualify. Get the vaccine, or at least ask more questions about it. But wear the mask, wash your hands, stay safe, stay strong. We're tough people. This tough time would not last forever.
People, you just heard it from one of the best in the country. And, you got to listen. If you don't listen to people like us, listen to people like Dr. Kemi. Dr. Kemi, I want to thank you once more for all you do, and help me thank your colleagues, help me thank those in the medical profession and other healthcare workers. Thank you.
Thank you so much.
All right.